All right, let's dive into something you're going to see all the time in clinical practice, vertebrogenic pain syndrome. Seriously, if you're hitting your ortho rotation soon, this is bread and butter. You have to know this stuff cold.
So, you've got a patient with back pain. It's probably one of the most common complaints you'll ever see, right? But the real clinical detective work starts with this question. Where is that pain really coming from? Is it the muscles, the disc, the bone itself? Nailing down that origin, that's the whole game.
Okay, so here's the official definition. It's super important to realize that vertebrogenic pain syndrome isn't just some generic backache. No, this is pain that originates from degenerative changes in the spine and all the structures that support it. That word right there, degenerative, that's the absolute key to understanding this whole thing.
So what's actually causing all this degeneration? Let's break down the pathophysiology. There are really three main culprits here. Think of them as the big three causes you always need to have in your back pocket for your differential diagnosis.
First up, we have the classic disc herniation, or hernia disci. You know this one. The mechanism is everything. That jelly-like center, the nucleus pulposus, literally squeezes out through a tear in the tough outer ring, the annulus fibrosus. And the problem isn't just a pain signal. It's the direct physical compression on those spinal nerves. This is often, one of the first dominoes to fall in that whole degenerative cascade.
All right, next we've got spondylosis, and you might see spondylarthrosis used too. Now, this isn't just one thing. It's more like a whole constellation of degenerative changes happening at once. We're talking osteophytes, bone spurs popping up, the space between vertebrae getting narrower, the end plates getting all sclerotic, and of course arthritis in those little facet joints. It's pretty much the definition of long-term wear and tear on the spine.
And our third big one is spondylolisthesis. Okay, listen up because these two terms get mixed up all the time. Spondylolysis, that's the actual defect, the fracture in the pars interarticularis. Then spondylolisthesis, that's what happens because of the lysis. It's the forward slippage of one vertebra over another. So just remember, the lysis is the break, which then leads to the listhesis, the slip. Simple as that.
Okay, so we've got the causes down. Now, how do we actually nail the diagnosis? Let's walk through the diagnostic pathway. You got to be systematic about this to get a solid workup.
It really comes down to three fundamental pillars. First, and always first, is the anamnesis. Just talk to the patient, get their story. Then you follow that up with a really solid physical and neurological exam looking for any deficits. Only after you've done that do you even think about ordering imaging to confirm what you're already suspecting. Now, when we get to imaging, you have to know which tool to use for which job. An X-ray? That's your first-line scout. Perfect for a quick look at the overall bone structure. A CT scan? That's what you want when you need that beautiful high-def detail of the bone, especially for tricky fractures. But for vertebrogenic pain, well, the MRI is really our gold standard. Why? Because it lets us see the soft stuff, the discs, the ligaments, and most importantly, if a nerve root is actually being squished.
All right, diagnosis is in the bag. Now it's time to talk treatment. The management strategy here really forks into two main roads, and knowing which one to take and when is absolutely critical. So let's look at this from 30,000 feet. The rule is you always start with conservative therapy. Always. The goal here is pretty straightforward. Manage the symptoms, get the patient functioning better, all without surgery. We only start talking about the OR if two things happen. One, conservative therapy just plain fails. Or two, and this is the big one, the patient starts showing serious neurological deficits.
So what's in this conservative toolkit, you ask? Well, it's a whole mix of things. We're talking pain management, your standard analgesics and NSAIDs. We might do more targeted stuff, like epidural steroid injections to calm down inflammation right at the source. And then there's a huge emphasis on physical therapy, getting that posture corrected, strengthening the core muscles, and teaching the patient how to modify their activities.
Okay, but let's say we do have to escalate to the OR. What are our options? Well, we can do a resection, which just means removing whatever is pressing on the nerve, whether it's disc or bone. We can do an osteosynthesis, using hardware to stabilize the spine. We could do a fusion, basically locking two vertebrae together to stop painful movement. Or, in some cases, like compression fractures, we can even fill defects with cement, which is what things like vertebracoplasty and kyphoplasty are all about.
Another really key concept here is that this syndrome isn't a one-and-done thing. It progresses over time. So let's talk about the difference between the early, functional stage and the later, structural stage.
In the beginning, the problem is almost entirely functional. Here's a great way to think about it.
It's a software problem, not a hardware problem. The pain is coming from things like muscle imbalances, bad posture, or just overworking those deep core back muscles, the autochthonous muscles. But here's the key. At this early stage, the actual structure of the spine, the hardware, is still perfectly fine.
But if that goes on long enough, it can progress to the advanced stage. And now we've got a hardware problem. We're talking irreversible structural damage. The discs are degenerated, and you have real physical compression of nerves by bone or that herniated disc material. This is where you start seeing those really concerning, true neurological deficits pop up.
Okay, that was a lot. So let's boil it all down to the high-yield summary. These are the points you absolutely have to know for your exams and for the wards.
All right, here are your take-homes. Number 1, this is all rooted in degenerative changes. Remember our big 3, herniation, spondylosis, and spondylolisthesis. Number 2, diagnosis is a 3-step process. History, exam, then imaging. Don't jump the gun. Number 3, treatment always starts conservative. Surgery is for when that fails, or you've got neurodeficits. And finally, number 4, remember the progression. It goes from a functional software issue to a structural hardware problem.
So I'll leave you with one last question to chew on. We know that failed conservative therapy is one reason for surgery. But what is the single most critical finding on your physical exam that basically forces your hand, that makes surgery not just an option, but an absolute necessity? Think about that next time you're reviewing the red flags for spinal pathology.